Greetings, everyone, in the webinar. We will just wait for some more seconds as I see a lot of people are still logging in, but we will start shortly. So, greetings to everyone. We have participants from many time zones today. So for some it's good morning, for some it's good afternoon, for some it's good evening. For me it's afternoon because I'm in Kabul currently. And first I will tell you that we had a late change in moderator. So it is not Kajsa Johansson, our Secretary General, who is moderating. She couldn't join us today. So instead it's me. My name is Kajsa Wikström, and I work with policy and communication in the Solidarity Committee. So thank you all for joining us, and also a special welcome to the midwives and midwifery students who are listening today. It's your day today, the International Day of the Midwife. And today we will explore a crucial question about what happens to women and newborns when funding for healthcare is reduced, and what can we do differently to minimize the harm. And our conversation will focus particularly on Afghanistan, where access to maternal health care has improved over the past 2 decades, but where those gains are now at risk. And our panelists today, first we have Sabira Turkmani. She is joining us from Australia. She is a midwife, also the co-founder of the Afghan Midwives Association and a researcher at the Burnett Institute and University of Technology in Sydney. We have Stefan Swartling Petersson. He's today joining us from Uganda, but he's in his day-to-day work, professor of global transformation of health at Karolinska Institute and also a public health physician. Then we have Kristina de Carvalho joining from Sweden. She is the lead policy specialist of health and sexual and reproductive health and rights at the Swedish International Development Cooperation Agency, SIDA. And we have Andreas Stefansson, who is also in Sweden. He is the former Secretary General of the Solidarity Committee for Afghanistan. So thank you all for being here. And I will also let you all know that this webinar is recorded, so you will be able to access it afterwards as well. So first of all, before we dive into the discussion, let us set the scene. So I will ask you, Sabira, please bring us to Afghanistan for a moment.
Right. Thank you so much. Good morning, good afternoon, and good evening, everyone, wherever you are in this world. Thank you for having me to join you in this important conversation on International Day of the Midwives. So today I speak not just as professional as a midwife, but also I'm going to be the voice of Afghan women and midwives who stand resolute in the face of extraordinary adversities at the moment. Afghan women are legendary. They are so strong and resilient. We are raised in a way to endure and carry out our burdens quietly, to find strength in silence, and keep moving forward with resilience and strength, often without asking for help. So when an Afghan woman raises her voice and asks for support, it's not a small moment for that woman. It means she has reached a point where her resilience and strength alone are not enough to survive. So, and the reality for many Afghan women is very different to what we see behind the numbers. Like when tonight, I want each of you attending this webinar ask a difficult questions. We must ask ourselves how much we have truly responded to call for help for Afghan women, which is now, I think, it's far more too long they are asking for help, and the international community not responding properly to those calls for helps. So we've gathered here today or tonight, wherever you are, to discuss maternal and newborn health in Afghanistan, while we're discussing the numbers and the statistics, but remember, behind all those numbers, there is a story. That's the important point to keep in mind. Because the lived reality on the ground is more difficult and full of hardship, something sometimes very difficult for outsiders to truly comprehend and understand. And statistics cannot capture those stories. For Afghan women, pregnancy and birth is not a time of anticipation. It starts with fear, uncertainty, and risks. Let me get you through some imaginary situation. Imagine you are a woman in a remote province of Afghanistan, like Ghor, Wardak, Badakhshan, those provinces with terrible maternal health indicators. Imagine you are a pregnant woman, nearest health facility to you at least 6 to 8 hours far. You need to cross mountains, snows, roads, which often are impassable. And even if you are lucky to pass those roads, sometimes those roads actually are destroyed by natural disaster or war. And if you are lucky to pass this barrier, then there is no vehicle. The only option for you might be, if you are lucky, you might have access to a donkey to be on and go to the health facility. Otherwise, you have to walk on your foot in the middle of the night while you are in labor pain in a very insecure situation, going to a health facility. If you are so lucky and save that health facility safely, there is no guarantee there will be a midwife serving you in that health facility. There is no guarantee there will be a female health provider there or any kind of trained health providers there. So how do you feel in that situation? You're not only thinking of yourself, you are thinking of your baby, you are thinking of your family behind. Delays in those situations is inevitable, and childbirth delays could be fatal. Now imagine the other side of the story, a midwife in that same community. You are the only trained providers who are serving thousands of populations. You are working days and nights, often without reliable support. You haven't paid your salary for months. You face serious personal risks because including threats from those who don't like you to work at your jobs. And also you may not have male escort to carry you to the health facility because that's the rule at the moment. And there are lots of gender norms that you need to follow in terms of being able to travel to be in health facility and work there. Then now imagine a woman arrives to you with postpartum or intrapartum hemorrhage and bleeding. You have the skills to save life, but you don't have the tools. There is no medication, no supplies, no referral pathways, no transportation. You are forced to watch a preventable emergency to become a tragedy because you cannot do anything for that woman. It's a devastating situation, not just for the family. It is deeply traumatizing for the health provider, for the midwife. Often you must refer women knowing that she may not reach the next level of care because it's too far, and it may take another few hours for her to. And by the time she gets there, the bleeding will kill her. And this midwife still needs to continue the services in that conditions because she knows that she is the only point of care for that community. The impact is massive. The gaps is ripple through the woman, family's entire community and push midwives to be out of the system. Not because we don't know what is the solution in that conditions, because the access to those solutions become increasingly fragile. The discussion today we have here is not just to understand those challenges. We need to identify some practical, innovative, and collaborative ways to support Afghan women and children. I'm going to hand over to next speaker, and we will come back to these issues more deeply in the next few minutes. Thank you, guys.
Thank you so much, Sabira, for bringing us into the mountains and the valleys of Afghanistan and the remote areas. It's a great reminder of the realities on the ground. And I will now let Andreas take us into more statistics and numbers, because the Solidarity Committee has just today published a policy brief on maternal health in Afghanistan. So, Andreas, please tell us some of the highlights.
Yes, thank you so much. I hope you can hear me. Yes. So good morning, good noon, good afternoon, good evening. Thank you for being here and together highlighting the International Day of the Midwife. Thank you, Sabira. I mean, that was really good to get that kind of on the ground picture, because as Kajsa says, I will now take us through some of the elements of this policy brief we have just published, and it will indeed touch on some of the statistics and trends. So to start with, the maternal and child health system services and indeed situation for women and children in Afghanistan is at a critical juncture today, and that is why we have published this policy brief. So we argue that there's a real risk of increasing maternal and child mortality now in Afghanistan, and at the same time that most of those deaths are actually avoidable. So urgent action is necessary and feasible to address that. So Afghanistan is among the most dangerous countries in the world to be pregnant, a mother, or baby. Every second hour, a woman dies from pregnancy or giving birth. That's around 600 to 700 deaths per 100,000 live births. And to compare with Sweden, I think it stands at around 4 today, 4 deaths per 100,000 live births. So although the situation is very severe in Afghanistan, there has been steady progress over the last 2-3 decades, and that is a progress that we now see there's a risk of reversal. And I'll come to the reasons of that a bit later. So if we just go back, we recap a bit about this progress. In the year 2000, Afghanistan had been in continuous war for about 20 years, was deeply impoverished. It had a very weak health service system. Less than 10% of the population could access a health facility within local travel means. It also had a repressive regime, Taliban version 1.0, that then also imposed restrictions, and there were also, of course, then gender norms that limited women's mobility and care seeking. So at the time, in 2000, it had one of the highest maternal mortality ratios globally, with 1,800 deaths per 100,000 live births. So 1 to 2 women died every hour from pregnancy or giving birth. Likewise, under 5 child mortality was also very severe, with more than 1 in 10 kids dying before age of 5. So what we saw then after 9/11 and the international intervention was a focus on rapid expansion of the health system, and then with a particular focus on maternal and child health services. So there was a concerted drive to establish basic health services, also eventually hospital services. And by the mid-2010s, there were about 3,000 health facilities operational across the country. So somewhere around 2/3 of the population could actually reach a health facility within 2 hours travel. But a major barrier from the start was then a severe shortage of skilled birth attendants, and particularly trained midwives then. So it's estimated that fewer than 1 in 10 births were attended at the time by a skilled provider. And an assessment in 2002 showed that only 467 birth attendants were available with some kind of formal training for a population of almost 30 million people. So there were many measures that were taken then that were very important to address this. So there was a community midwifery education program that was scaled up, Institute of Health Sciences midwifery program, and Afghan Midwifery Association was established, which I believe we will hear more from Sabira on later. And 2-year courses were established that focused on training women to become midwives, and particularly rural women that then were deployed back into the rural areas where maternal mortality was highest. And by late 2010s, about 7,000 qualified midwives had been trained. So again, compared to just 467 15 years earlier. So together with expanded humanization and improved child health services and also broader social gains like education, we know that when women get educated, the longer they study, the later she gives birth, the less risk for complications and so on. But also other gains within women's and child rights contributed then by 2020 to maternal mortality having halved and child mortality likewise halved. So that's a very significant improvement. So now if we look at what the situation is now after the Taliban return in 2021, gains have stalled, and we today fear that the gains are at risk of reversal. So there's a health system that has been very aid dependent throughout. Some 80 to 90% of the system is funded by foreign aid. And with the regime being non-recognized, foreign aid cannot be channeled through the public health system. So it has to be done off budget. So it goes through the UN and onward to NGOs. So you have a health system that's governed in a fragmented way, where there's lack of national ownership and accountability. So there's a lack of clarity on policy setting, and it kind of undermines sustainability. And then furthermore, what has been detrimental as of 2025 is the US aid closure. So US aid has stood for about a third of the financing. So this has been a major blow. And today it's estimated that more than 400 health facilities are closed due to the reduction, also by other donors. So that's about 15-20% of all health facilities. Then you have a situation in the country with a protracted humanitarian crisis. So there's rising poverty, acute food insecurity, malnutrition, also compounded by large-scale refugee returns from Pakistan and Iran, and then lately also regional instability. We know the war in Iran, of course, but also tensions between Afghanistan and Pakistan that then limit medicine imports and disrupt health services. And to make matters worse, the future pipeline of female health workers is also threatened by restrictions by the Taliban regime. They restrict girls to study beyond grade 6, and have also restricted female health training. So what we see is that while health needs are sharply rising, the response capacity of the health system is eroding. And this taken together then points at worsening outcomes. So the UN projects that there will be a substantial rise in maternal and neonatal deaths in the coming years. Now, this is a very grim picture, and one can ask oneself if there are any opportunities. And I'll quickly point at 3 before we move on. Firstly, women are actually still permitted to work in the health sector. So while women are prevented from training to become health professionals, there are existing women working within the health system. So one can reach out to strengthen the existing women and the existing maternal and child health services that actually indeed exist in the country. And one can find ways to finance so that the closed facilities could be reopened and new ones established. Secondly, there is an existing pool of unemployed women with midwifery training. So there's a potential to target them, to upgrade the skills, certify, and get them deployed. And thirdly, the demand for maternal and child health services remains strong. This is evidenced in various research that particularly, not only in urban areas, but also in rural areas, there's improved awareness, there's increased health literacy, and there's support by family members and community leaders. So there is demand, and utilization is not mainly constrained by lack of demand, but it's actually by the insufficient supply and access to MCH services.
Thank you very much, Andreas. I will now like to go back to Sabira. You are in the Advisory Council of the Afghan Midwives Association, and that we call AMA. And AMA is also a long-standing partner of the Solidarity Committee. Since you're in close contact with midwives on the ground in Afghanistan, what does the impact of those aid cuts look like on the ground in Afghanistan today? You're muted, Sabira.
Sorry. Yeah. Thank you. Thank you, Andreas, for highlighting such critical issues in that policy brief. The aid cut is not only to make the budget smaller or reduce program implementations. For women in a remote village, aid cut means clinic is closed. For midwives, it means there is no salary. For the system, it means there is no medication such as oxytocin to stop bleeding and survive a woman, and no pathway for referral. No fuel, nothing is available for the health system. And for midwives, at the middle of all these chaotic situation, conflict, adversity, funding crisis, I think there is still source of hope because the midwives remained on the ground and they are providing services to the community. And organizations such as Afghan Midwifery Associations providing services to the midwives, communities, women, children for decades, especially last couple of years after return of Taliban. Despite political fragility, economic hardship, and system disruption, AMA continues their amazing work in partnership with organizations such as Solidarity Community and UN agencies. In the past couple of years, AMA was able to build capacity of hundreds of midwives, especially those in rural and underserved areas, through their mentorship program, which supported by Solidarity Committee, some part of those professional development, and supportive supervisions, mentorships, and all other type of on-the-job trainings. They help to improve not only the quality, also still ensure the community that some level of quality is still exists within the health system. During emergencies and natural disasters, AMA has been mobilized its resources and members around the country to reach thousands of women and families and help them during that. For example, during influx of migrants from Iran in the border, AMA had a very key role on helping women and addressing their needs. During natural disaster, earthquakes, AMA was critical because the health system literally cannot do anything for those women. And those kind of organizations like AMA, if they are not on the ground, no one is there to help those women. AMA has also pioneered midwife-led model of care in Afghanistan for the first time, a modern way, a modern approach of providing midwifery services to women. At the moment, they have 3 midwife-led maternity centers across the country and 12 community-based satellite midwifery-led units in provinces such as Wardak, Farah, Logar, and Kabul. These services run purely by midwives. It's cost-effective and improve outcomes. At the moment, we are at the middle of an evaluation of these services, and the results will come out soon. And the evidence is compelling that it's cost-effective. It's improving outcomes. Just listen to me closely. The primary results of our costing shows that for each $1 you spend on establishment of midwife-led center, the health system could realize approximately $4.3 in economic return. Imagine if you spend 1 million, you will realize 4.3 million return back to the health system, largely through avoiding hospital costs and additional health gains. Like, why not we should spend on that? And midwives, Afghan Midwife Association, in partnership with partners like UNFPA, Solidarity Communities, at the moment running a couple of them, but we need to expand that. We know that the solution are midwives and midwifery services, and the strategy is to expand midwife-led services in Afghanistan. And Afghan Midwifery Association at the moment is doing that with lots of challenging, because the situation for midwives themselves becoming increasingly difficult, and the pipeline of future midwives is under serious threats. Many of our most experienced qualified midwives forced to leave the country. Those who remained in the country, they're facing with mountains of challenges like chronic lack of resources, shortage of support. I know midwives who worked for months and years without salary. How long they can continue? I don't think very long. No. And there is no professional development to be implemented systematically. It is very concerning because we are not just losing health personnel, we are losing the very foundation of our health system, which are midwives. At the same time, there is a concerning narrative coming up recently, which some of the organization recruiting providers, which they so-called poorly trained providers, and they thought they can replace qualified, competent midwives. I want to be clear at this point to anyone who is attending this call. Please send this message to anyone who is implementer of such programs. It is not safe, not evidence-based, and not effective solution for providing quality of maternity services to women and children in Afghanistan by poorly trained health provider. Insufficiently trained health providers are significantly more likely to miss complication and delay life-saving care, which contribute to higher maternal and child mortality. You either trained a qualified midwife based on ICM standards, or you are not training a midwife. There is no middle point. There is no middle ground when a life is on the line. Afghan women need and deserve the best quality, respectful support delivered by a qualified, competent midwives. So Afghanistan's situation, I accept that it's unique. It's donor dependent at the moment, totally. But let's think smartly, innovatively, and centering the choice of women at the heart of our actions to see what we can do that is more innovative and more effective for those women. I'm not sure if I answered your question, Kajsa.
Yes, you very much did. Thank you, and for showing the opportunities that still exist. Now we're going to broaden the perspective and talk about what happens when maternal and child health care is deprioritized or neglected. And we will also broaden the perspective to become a bit more global. So, Stefan, what are the long-term risks when maternal and child health services are weakened?
Well, thank you. I draw a lot on my experience when I was UNICEF's Chief of Health, and then I discussed with Deepika Atigale in the UNICEF country office in Kabul, also to put some Afghanistan context on this question. Certainly, we've already heard about the numbers here. And in fact, there are about 10 million women in Afghanistan of reproductive age, and they bear 1.45 million children every year. So that's a lot of deliveries to take care of. Andreas told us the statistic here that the maternal mortality ratio is 500, and that or above. 500 per 100,000 live births. And that puts Afghanistan, unfortunately, at the top end of mortality, maternal mortality in the world. By comparison, which Andreas also did, Sweden has 4, but let's say 5. So there's a difference of 100 in mortality risk between Sweden and Afghanistan as it is. Now, we followed, of course, the progress very acutely, and we tried to help out from a UNICEF side here. But the question here is that there is a risk of deprioritizing this care, as we heard, and the fact that Sabina talked about, that you cannot let girls go to secondary school and you cannot train new midwives, means that we're also running out of midwives. And if we don't pay them, it gets even worse. So UNICEF put out a report last week. It's called The Cost of Inaction, saying the 2.2 million adolescent girls who are out of school now are now added another 400,000 every year who cannot go to school. Now, what happens here is that typically there is early marriage when you don't continue going to school. We already heard about that. Now, early marriage increases the risk of both to the mother and the baby. So there are even projections that maternal mortality ratio can go up, and certainly that the newborn mortality ratio can go up. by as much as 45%, according to some estimates. Now, this is obviously a human tragedy, but back to your question, it also means that you are losing economic development for the country. This is the UNICEF report last week quantified this, saying that Afghanistan is losing $84 million per year by keeping girls out of school and doing these things. And if you add the maternal mortality on top of that, that's another loss. So I think one element here is that we are used to talking to the Ministry of Health, but I think we need arguments to talk to the Ministry of Finance as well, because this goes far beyond the human tragedy. This becomes a tragedy for society at large and to the economy. So it has widespread consequences, Kajsa.
Thank you, Stefan. But could you then also maybe show us some positive examples of how healthcare systems can be strengthened to reduce those risks?
Well, you know, briefly, I wanted to touch on both Sri Lanka as the leader in the world and Uganda, where I'm at. Sri Lanka, around 1950, had the same maternal mortality ratio as Afghanistan today, around 500. However, today, Sri Lanka is at 20. So they've gone from 500 to 20 in 75 years. And how did they do that? Well, they put out midwives. They sent girls to school and they built universal health coverage, universal access. So they had qualified midwives who actually assisted in deliveries that came to facilities. And in 75 years, they made this leap from 500 to 20, which is nearing Sweden at 5 then, right? Now, in Uganda, where I am today, in the last 25 years, Uganda has gone from 300 to 170. So it's still far from the SDG target of 70 maternal mortality ratio by the year 2030, but still it shows that progress can be made. And in the case of Uganda, I've been coming and going for 25 years. 25 years ago, 10% of women had skilled birth attendant in facilities. Today, it's 90%. So midwifery-led models in community and in facilities are key. And I have midwife colleagues from Sweden who actually work here in Uganda with a midwifery-led model where you also respect the mother's dignity. She can choose her labor position. There is no hitting, etc., but rather you turn on the oxytocin pump by talking nicely and stroking the woman kindly. A project called Midwives. So there are ways. We know how to do this. This is about making arguments to whoever is in a decision-making power. And as I understand that the Swedish government now is going to engage the government of Afghanistan, I think this belongs on that agenda at the top. Thank you.
Thank you, Stefan. And there you mentioned Sweden towards the end, so that will bring us naturally to Sida and Christina, because I would ask you, representing Sida, how in the current times when there are limited resources, but at the same time there are enormous needs, how is Sida prioritizing in this?
Thank you very much, Kajsa, and thank you, Solidarity Committee for Afghanistan, for hosting this important seminar today. Yes, for Sweden, SRHR, gender equality and human rights have been long-standing priorities for foreign policy and for development cooperation. And at the heart of this conviction is that every person should have the right to decide on his or her own body and life and future, of course. And what we're seeing today in Afghanistan is, of course, very tragic. But we also know that gender equality, and in particular SRHR, is being increasingly challenged, not only in Afghanistan, but globally through restrictive laws, shrinking civic space and attacks on women's autonomy. And in this context, Sweden does not remain silent. We continue to speak out and contribute with financial support. And the last figure I have is from 2024, but we foresee that it will remain for also for 2025. The Swedish official development assistance for SRHR was 5.5% of total ODA, corresponding to 2.7 billion Swedish crowns. So to your question, the government steers SIDA through strategies. It can be global, thematic, regional, or bilateral. And we know that the government recently last year decided to phase out the bilateral strategy for Afghanistan. So that is the political steering we have to relate to. But if we talk of SRHR and health in general, we see that these are topics that are prioritized for the government. As seen in there are two main strategies for that thematic. It's a thematic global strategy for health and SRHR, and also a regional strategy for SRHR in Africa. And these two strategies did not receive any cuts, while almost all bilateral strategies have been decreasing. And the phase-out decision is a clear signal for the government, but there are other strategies that are also providing support to organizations that are working directly with Afghanistan. And we, for example, have, of course, the humanitarian strategy that is the largest one previous years due to, of course, the humanitarian crisis. Then we have the thematic strategy for migration. That is also a prioritized strategy for the government. And the thematic strategy for gender equality. And the one.
Okay, now we might have Kajsa coming back. I just
Anyhow, post the question.
Who needs to do what? I mean,
I think
knowing that we are in a situation now where USAID funding is likely not going to reappear in the near future, and we see this global kind of contraction, and at the same time we see these immense needs. I mean they're formidable challenges right now, and which actors can play a key role, and how do we tackle these challenges?
Well, I think you gave me the easy question. Now I think we're all reeling under these adjustments, right? And I think one thing that is hopeful is that I don't think that the political talk we see now and those effects do not necessarily reflect how the general population in the previous donor countries feel. I think the Swedish population still cares about women and children. So I think one is what we do in the elections in September in a country like Sweden, making sure that we reinstate some of these support mechanisms. Now, Sweden cannot cater for all the needs, though, obviously. So I think we also need to make these arguments wider, and we need to make them to new audiences, including regional development banks, but also in an era now of security and resilience, etc., to the military establishment, because this is also a security situation. The Middle East, to stabilize, will need a stable Afghanistan that is making human progress. or this will continue to destabilize the world. And I think all the surrounding countries and all the world powers, present and aspiring, we will need to do the difficult task of actually having this discussion. And maybe even unusual players such as energy security. When are we stepping in with these countries and saying, okay, we need a stable region for energy supply to be there? So that is at the big level. At the country level as well, I know Afghanistan is in a very difficult situation, but as UNICEF, if I may put that hat on, it's important that we talk not only to Ministry of Health, but also to the Ministry of Education and the Ministry of Finance and the Prime Minister, because usually it's the Minister of Finance who is the strongest in the government. And we actually show that this is not just a question about the human tragedy. This also reflects badly on economic growth and other things that finance ministers appreciate.
Kajsa, I see that you're back.
I am back now from
I'm glad
home.
to return the
stepping in,
moderation
Andreas.
to you.
Yes, it was good that we shared the rundown beforehand. So now we will go to Sabira, because you have some recommendations specifically for Afghanistan.
Yeah, great. Thank you so much. Stefan mentioned that given the current political and operational constraint in Afghanistan, I think the most effective way to reach women and address their needs is community-based intervention. And those are the only viable and effective ways or options to reach women. And I think in partnership with local organizations such as Afghan Midwife Association, supporting and expanding midwifery-led model of care should be at the heart of any intervention any donor wants to consider. The second thing which I'm thinking, which is from my point of view as an Afghan, which might be very effective, ensure that existing human resources are not lost, but strengthened. For example, these 34,000 of midwives who trained by private sectors, and they are unemployed and they are in the community and providing poor services, they are very dangerous at the moment. We can't upgrade them, upskill them, as Andreas mentioned in the policy brief. One practical solution is to institutionalize national capacity building for midwifery education, like a bridging program, and upgrade them through AMA Center for Research and Education Excellence, which building on existing efforts within AMA. AMA has a Center for Research at the moment. We can add component of education to that and use the existing capacity and play a critical role in systematically upgrading competencies of midwives, make them safe to be deployed, and provide respectful and safe services to the community. Under a very well-known professional organization such as Afghan Midwife Association. The other things which I'm thinking, I'm not a finance expert, but I'm looking from the local perspectives. We need to be more innovative in funding opportunity or funding approaches. One options which I'm thinking about these options for long, and I think it will work in Afghanistan, but we need to try it anyway. The trial is the main thing for anything. Blended financing, where international aid is combined with private investment. Then to share the risk and mobilize additional resources. This could be particularly effective for strengthening midwifery education, the bridging program, for example, we are thinking to do, upgrade midwives. And then you have this private sector, they can put their money or funds with international aids and then channel it through Afghan Midwife Association to have more effective, rather than an organization who have no experience of training of midwives, run midwifery program, and then poorly trained health providers go to the community and increase maternal mortality. That may not work. So that's one way. And then we can explore also performance-based financing mechanisms that directly support midwife-led services by linking funding to the quality of care delivered by midwife-led services. This can incentivize higher standards, strengthening accountability of those who provide midwife-led services, and also we ensure that resources are used effectively. That's my recommendation, and as I mentioned, we need to try it to see if it works, because the situation in Afghanistan is very unique and special.
Thank you, Sabira. And then over to Andreas for the recommendations from the Solidarity Committee. And please be brief so we have time for some audience questions in the end. Thank you.
So what we set out in the policy brief are basically three key recommendations. So one is to sustain funding for maternal and child health in Afghanistan, and we've touched on that here. And I think that Solidarity Committee plays a key role in well, things like we're doing right now to actually highlight the needs in Afghanistan and ensure that the world does not forget Afghanistan. And here, I mean, it's quite frustrating because the international community repeatedly affirms that it's committed to Afghan women and children, and we hear it sometimes by politicians in Sweden as well. But this should not remain as lip service, and failure to sustain support in Afghanistan. I mean, we see hundreds of facilities closing now. We see the reversal of child and maternal mortality. Failure to sustain support in this critical time amounts to a betrayal of the commitment to the Afghan women and children. So we have a key role here. Then a second recommendation is to strengthen frontline health providers. And Sabira gave us a very clear idea of how that can go about. And of course, we are then partnering with AMA in trying to enable that. And I think that we have a role in continuing to mobilize support. And Sabira, you also pointed out that, of course, private foundations and philanthropists should also be mobilized at this critical point. Thirdly, the issue of allowing women to study and train as health professionals. And that's, of course, a recommendation that goes straight to the Afghan authorities. And what we believe is the long-term solution to many of the challenges that relate to the regime in Afghanistan is, of course, to see change come about from within and below in Afghanistan. And that's easier said than done, but we know that there is a demand, as I mentioned earlier, demand for health services, there's demand for maternal and child health services. People want to defend the services they have. And if we can find ways and means to reach out to them in their defense of that, they also have an opportunity within their local areas to mobilize, voice, organize, and start to put pressure from within and below. We know that health authorities, many of the Taliban leaders, indeed would like to see better health services and also girls getting educated. And in the long run, this change, the pressure for this change has to come from within and below. And we as an actor can reach out and support those actors on the ground that play a key role in that, including AMA and its advocacy. I mean, AMA is a very important advocacy actor in Afghanistan, being grounded and having the 3,500 members and being respected.
Thank you, Andreas. And then last, Christina, what do you see as important steps going forward?
Thank you very much. Now, I also wanted to add, we have heard about the AMA several times and their importance, and SIDA is supporting the International Confederation of Midwives, where I think AMA is a member and where they are working very closely, especially you mentioned guidelines and related to midwifery, that is really important to keep up the quality, of course, of the services that are provided. Another important initiative is the Midwifery Accelerator, that it's a collaboration between the UN, where ICM is one partner, but also UNFPA, WHO, and UNICEF, where they are trying to push the broad role of the midwife. That is, we know it's not only around just pregnancy, but also support to families to plan about pregnancies and also avoid pregnancy when not wanted. And also the time after, of course, after delivery, where a mother may not feel the best and could provide psychosocial support as well as detect gender-based violence. So I think the midwife's role is very broad, and I think we need to think of that important health professional as not only around this pregnancy. SIDA is also then supporting the UNFPA Maternal and Newborn Health Fund, that where Afghanistan is one of the priority countries. So I think there is opportunities there as well. But going forward, I can only agree with what Sabira and Andreas had said, that our experience is also from working and supporting organizations in Afghanistan is to support local organizations and the community level. And there the partners have seen change in attitudes, in behavior, where also community leaders have changed attitudes in relation to women's and girls' health, and also the importance of them providing, getting access to this health. Of course, when funds is limited, donor coordination is another issue, pooling funds and coordinated, supporting systems and structures when possible, and also a flexible support when things happen, earthquakes, climate change, crisis, and migration. So in that sense, these are the takeaways that Sweden have had after many years of supporting Afghanistan, and also in the continued support to Afghanistan directly or indirectly. Thank you.
Thank you, Christina. We have one question in the chat, and it's from Erin in Kabul, who writes that working in the extremely difficult circumstances described by Dr. Turkmani has a real impact on midwives' psychosocial well-being. This in turn impacts their ability to provide respectful, high-quality care, ultimately impacting health outcomes. So Erin's questions to you, Sabira, is what can be done for midwives' well-being?
A very good question. We need the highest level of policy advocacy for midwives to be supported, and not just the many things contributed to this mental health impact of war and fragility, not just on midwives, any other health professional in Afghanistan. My call is that we need advocacy at the highest level of policy in Afghanistan. I don't think the current government would easily accept that this group of women who call midwives, they are very important for the health system and they need support. But we need to continue advocacy and support. The other way we can support them is international community. It's at the moment, they are hopeless, they are helpless in the country. The women are in a very fragile situation. They have no access to education, no freedom of choice, no freedom of mobility. What international community can do? at least be their voice outside Afghanistan. The war, I feel, as an Afghan woman, the international society is silent when it comes to Afghan women and midwives and anybody, Afghan women in overall. Like we need international community to be our voice outside Afghanistan and do something, like not just talking about it, but action it. And mental health support is very, strategic, but it's possible. And you can just run a session for midwives online to talk to them, to support them. They should feel the support from international community. At the moment, they feel so lonely and isolated because they feel no one hear their voice and no one support them. The first thing happened to Afghan Midwife Association, they pull out the money from midwife-led unit. The only means of support for few midwives who can work and earn money for their family and their community. They just pull out the funding. How much it was? Not too much. Like midwife-led services is very cheap and cost-effective. And these midwives, that was the only source of income for them. And the first thing happened after return of Taliban, the donor pulled out that money. Then gradually other source of funding pulled out from the system, which is understandable with the current climate of political climate in Afghanistan. But what we can do, be voice of Afghan women and midwives at international level, and do what you can do at your level. Run an online session for midwives, provide them opportunity for professional development, even if it's online. Like channel your financial framework towards midwifery and Afghan women if you can. And seek other ways, non-traditional ways of funding things. Like I heard that some charity organization channel money from other ways, non-traditional ways, to women in Afghanistan, which I really appreciate as an Afghan woman. Like you don't need to go through the Ministry of Health always to do that. And we know what is going on within the health system in Afghanistan. There are more reliable and trustworthiness of ways to give money for doing good things in Afghanistan. Don't look at supporting Afghan women as a charity. It's not a charity, it's a responsibility. You need to do that as part of your responsibility as international community. And if we can't support them, I don't think we can do anything in terms of psychological support for Afghan women. They are isolated, they are voiceless. Be their voice and support them as much as you can at the level of your authority.
Thank you so much, Sabira, and thank you for being the voice of Afghan women here in the seminar today. And for those of you who want to read more and learn more about maternal health in Afghanistan, you can always visit our website, solidaritycommittee.org, where we have the policy brief that Andreas was talking about, or in Swedish, sak.se. And thank you all for listening. There was a big attendance today. I think we had like 85 people who can now continue to talk about Afghan women and the midwives in Afghanistan and the great work that they are doing. So thank you so much to everyone who was listening today. We're just out of time by 1 minute. So thank you to the great panel. We would have loved to hear more from you, but this was the time we had today. So thank you all.
Thank
Thank
you.
you.
Thank you.